Okay, good afternoon everyone, and welcome, and thanks again for joining our webinar today. My name is Brittany Quimby and I'm part of the marketing team here at Nightingale, and I'm joined again by Andrea Rennie, Manager of Healthcare Consulting, who will be presenting today's webinar on how to capture your access bonus potential. So I'm just going to go through the learning objectives for today. So today's webinar will cover several learning objectives, including increasing your understanding of the access bonus payment, identifying key strategies to manage outside use and improve your access bonus, and we're going to help you discover ways to help you manage your outside use. So a little bit about Nightingale. We are Canada's leading cloud-based EMR company with over 12,000 providers using our system. People choose Nightingale because we have a secure system, it's a robust system, and we are a proven leader in our industry. We offer personalized workflows for our customers, have great company stability, and pricing that works. So one thing to note, this is not a Nightingale demo. This is the third in a series of online educational events that we've done with Cirrus Consulting. Our goal with these webinars is to provide useful information on a relevant healthcare topic from industry experts. So again, for additional information on this webinar or to sign up for future webinars, you can contact us using the information that is on your screen. So at this point, I'll pass the reins on over to Cirrus Consulting Group. The presenter today, as I mentioned, is Andrea Rennie. We'll have a brief Q&A at the end of the webinar, so please leave all your questions until then. All the questions can be typed into the chat box that you have on your right-hand side of your screen, and we will do our best to go through all the questions at the end of the webinar. However, if we don't get to your question, don't worry, we will be following up with each of you individually for any unanswered questions. So at this point, I'll pass on over to Andrea, and we can get started.
Hi, everybody. Thanks for signing online midday today to talk a little bit more about access bonus potential and how to manage outside use effectively. Thank you to Nightingale and to Brittany as well for the little intro there, as well for inviting us to chat on these topics throughout the last few months. As Brittany mentioned, my name is Andrea Rennie. I manage the healthcare consulting team here at Cirrus Consulting Group. And we are pleased to be able to talk a little bit more about access bonus today, an area of the full model specifically that often is not taken advantage of to its fullest potential, and it's very gray to a lot of people. So I'm happy that we can finally shed a little bit more light on this for everyone. As we jump in, let's just run through some quick facts. Family physicians are now better compensated in Ontario than anywhere else in Canada. More than 75% of all physicians say that their pay does not align with the care that they deliver. We exist to try to close that gap for you. We want not to try to find additional things that you can bill for or to not bill properly, but we want you to better align the pay and the bills that you're actually submitting. Many physicians believe their access bonus will never be positive. And in the last round of ministry and OMA negotiations, as you know, there was nearly negation implemented for negative access bonuses. And we'll talk a little bit more about that as we move through. It's important to correct this before the next round of negotiations, where this could very much still be on the table during the next round. Access bonus is one of the greatest income generators in the faux model if managed effectively. And we have always recommended to focus on outside use from the early days of starting in the faux, and to get into the ongoing habit of staying on top of it, because patient behaviors do change over time. It's not something that we can look at once and then never revisit again. It has to be an ongoing process in the faux model. So the purpose of today is to increase your understanding of the access bonus payment, identify key strategies and manage outside use and improve access bonus, and to discover some Cirrus tools to help manage outside use. A little bit about us. We're founded in '94. We have 50 employees headquartered in Toronto. We provide practical business solutions that allow healthcare professionals to concentrate on what they do best, which is provide quality patient care. Now, we're mainly comprised of two specialized business units. One is the office lease negotiations with over 500 that occur per year. This is both for physicians and dentists across North America. And the healthcare consulting division, which is where we're sort of coming from today, which is billing support and operational consulting for physicians, both for groups and individuals. We help physicians and staff to optimize income, increase efficiency, and flexibility. We work within all models, FIGs, FOs, FITs, with both groups, individuals, and physicians. Today we're focusing on Access Bonus, which is a FO and FIT program. So we're sort of segmenting things today. Doctors leveraging Cirrus services see an average of income increase of between 15 and 25%. And the hours saved by engaging Cirrus as a group is approximately 1 full-time work week per month. We've helped hundreds of offices across Canada and thousands of physicians within Canada. Now let's talk a little bit more about how the actual program is established and some of the effective strategies on how to manage your outside use most effectively. So first, let's start with how the program is set up. So your access bonus, on this slide, what I'd like to show you is just a typical breakdown of faux physician income across the 5 different faux income streams. So capitation payments, fee-for-service, access bonus, shadow billing, and preventative care. All of these different streams make up 100% of your income. 5% typically is made up of access bonus. We'd like to see this much higher because there are ways in order to increase that access bonus, which we will get into. So it's a bonus paid on the level of access a physician provides to their overall roster. It's over and above the capitation payment that you receive for having the patients on the roster. There's an average potential of $62,000 per year in bonus potential, and that's based on the average physician's roster size of around 1,500 patients. However, that $62 grand is reduced dollar for dollar for faux in-basket services provided to enrolled patients by a physician outside of the faux. Meaning, if one of your enrolled patients goes to a walk-in clinic and has an AO 07 billed on them, that will be reduced dollar for dollar from that $62,000. It's also paid out based on group performance. So negative members of the group will impact those who are positive, meaning if one physician of the $62,000 after the ministry fiscal year ends, they're left with $5,000 left over of their access bonus potential. There's another physician within the group that's actually in a negative $5,000 position. The negative physician will not have to pay back that money to the ministry at this point. That's what the ministry was proposing during the last round of negotiations. But it will impact that positive physician within the faux group. So both physicians will be left with 0 access bonus. So how do we manage outside use? So some of the risks to managing outside use, as you know, are it's hard to control patient behavior. This is why many people believe that they will never have a positive access bonus position because there's a number of walk-in clinics around them, or they can't control such a large roster. All of these things we have heard before, and we've worked with physicians across all corners of the province and have been able to move people into a positive access bonus position. Patients are unaware of the impact when seeking care outside. Most patients have no idea that when they go to a walk-in clinic or they go to a sports medicine specialist that unfortunately they are impacting you negatively. No open appointments. Outside use is a daytime access issue. Without access to your office throughout the day, your outside use will automatically be higher because patients are demanding care and can't get in to receive it. So if we have no open appointments available, that impacts accessibility within the office. Referral patterns is another big one. So if you are consistently referring to other family medicine physicians within your community that do not have the focused practice designation by the Ministry of Health, they will ding you in outside use. And we'll go through some of the areas which are most common. I should also make mention that it's only family medicine physicians that impact outside use. Specialists do not. Patients are unaware of after-hours care available to them. Typically what happens, and what I hear from most of the physicians that we work with, is that you have that initial conversation with your patients when they first sign the enrollment and consent form, when you first start the FO, and then no one ever has that conversation again. Or that message just isn't clear to patients that after-hours care is available to them, and it's a great resource for them for the consistency of care, because you and your colleague will then speak about that interaction afterward. So some outside use best practices that we like to champion with the physicians we work with. We like to analyze the data to determine which patients to move from the roster to fee-for-service. So every month you receive your outside use management report, which will show you who your enrolled patients are that have gone outside of the practice to receive an in-basket services. It lists it for you every month. We like to go through and try to do a bit of a cost-benefit analysis to determine at what point it makes sense to potentially de-roster somebody. Now, let me be clear that it does not mean that you are no longer their family physician and that patient cannot come and see you anymore. That is absolutely not the case. All that changes is the administrative relationship between you and that patient in the eyes of the ministry. So you're just moving them to see them on a fee-for-service basis. You can de-roster retroactively back to the earliest date of outside use, which is a maximum of 6 months. As I mentioned, outside use is a daytime access issue, and you need to ensure that same-day urgent appointments are available. Without accessibility, outside use will climb. Ensure front office staff understand the FO program. Most people, when they transition from fee-for-service to FO or from FIG to FO, staff didn't really get any type of heads up really about how the world changes a little bit in the FO program. The staff are your absolute greatest ally in being able to spread the message out to patients that walk through the door about after-hours care and try to discourage them from seeking care at a walk-in clinic for the purposes of trying to keep their care consistent. Educate patients on what it means to be in the FO. So 4 and 5 really go hand in hand. Both you and your staff have the ability to really educate patients on the advantages of being a FO member. And we want you to be aware of red flag codes. And I want to talk a little bit more about those codes that we are identifying. Patients who use the following services are usually chronic contributors to outside use due to ongoing relationships with other GPs that do not have the focused practice designation. General assessments, of course, AO03s, if that's popping up on your outside use report, it could be a sign that they are starting a new relationship with another practitioner. That's not a code that would typically be billed within a walk-in clinic. So that is one that we certainly want to highlight for you. Special visit codes, all of the B codes. If these are popping up, again, it's a bit of a red flag as to what's happening with that patient. Focused practice assessment codes are one of the greatest contributors, and the reason for this is that they are high dollar value codes, so they really drive down that $62,000, for example. Sports medicine, allergy, pain, sleep medicine, addiction, and elderly care all are in-basket services for the majority of those codes, and if they're provided to enrolled patients, that will reduce your access bonus. Again, I need to make it very clear that this is only for CFPC certified family physicians that are billing family practice codes. This is not for specialists. Palliative care also contributes, as well as psychotherapy, which we see as one of the greatest contributors to driving down access bonus potential. Because once those relationships are formed, typically that patient is going back to see that physician on an ongoing basis. So the impact of derostering, let's talk about when you want to switch the relationship with your patient to have them from enrolled to fee-for-service, what happens? So it changes the administrative relationship between you and the patient. It moves them from capitation to fee-for-service. So think of it as changing it from being prepaid to being paid for each encounter, sort of the old way of doing things. Logistically, what happens when somebody is derostered is you will be deducted the capitation payments that were paid during that period. For example, if you knew somebody that was going to sports med physician for the past 6 months, you know now that they are dinging you heavily in outside use. So if you want to go back retroactively and deroster that person, you can go back 6 months. However, the ministry will deduct the capitation payments that were paid to you during that time. However, any shadow billing that occurred during that period will be topped up to the full fee-for-service value, but all of the outside use within that period will be removed, and you will be able to recoup that on your access bonus potential. Going forward, you can provide the same care, but on a fee-for-service basis. Patient management and outside use, incredibly important. Accessibility is #1 when trying to manage outside use effectively. So it's a daytime access issue. You need to ensure same-day urgent appointments are available. Assess the needs of your patients. Review which days of the week seem to be busier with walk-ins and call-ins. Typically, it's Monday through Wednesday that are the busiest for most physicians. Provide extra hours and more open spots on busier days and less on quieter days. For example, try scheduling physicals or longer appointments on quieter days. For example, if outside use spikes on a Wednesday, ensure open appointments are on Tuesdays and Thursdays. So being able to sort of schedule your day in a smart way in order to be able to accommodate for patient accessibility within your office. The bottom line is that patients need access. We can do all of the derostering and whatnot in the world, but if you aren't available to the patients, or if you don't have enough open spots available, your access bonus will continue to be negative. So some of the scheduling models that are often talked about, so the traditional model, as you know, are 100% booked appointments. Can't get in unless you have an appointment. The second model, which is the one that we sort of encourage our clients, because most have are slowly moving from traditional to a bit more of a carve-out model, where you have 50% booked appointments and 50% open appointments, but being strategic about where those open slots are. And then the advanced access model as well, which is quite popular within the province. A lot of people are doing it now, but there are implications to making sure that this goes off smoothly. For example, that if there are other physicians within your office, that they too are taking on that advanced access model, or what often ends up happening is you end up seeing their patients throughout the day. So there has to be a lot of thought and planning that goes into that. So we like to encourage people to do the carve-out as it is. It's a greater step in the right direction from a patient accessibility standpoint. Patient education. I cannot put enough emphasis on this, that this is so incredibly important. So when you're rostering, have the conversation about faux commitment and leverage the staff to spread the message about after-hours care, consistent care via another faux physician, and this really resonates with people too. When you know that you're going to another physician that is a colleague of my doctor, even though my doctor may not be available for me, that gives me a little bit more comfort to know that they will be able to report back what happened during that, so that they're aware of what was prescribed to me or the interaction that took place. Make sure that there's communication within your office and that goes out from your office. Posters, letters, cards about after hours, or a central phone line that they can call into in order to find out where the after hours care is for that day. And as you know, ensure open slots for same-day access are available. However, some of what most people often say is, it's not the patients that come into my office that are the problem, it's the patients that don't ever come in. And they're the ones that are tougher to reach. So that really, you have to then extend yourself sort of outward in order to get the message out to them. So a way of doing that is if you do a block fee, put a letter into that annual communication that you put out in order to encourage patients to come to your practice and provide them with all of the information about after-hours care. A lot of physicians are now collecting email addresses in order to push information out to patients. This does not have to be fancy. People can write down their email addresses, and this can go into an Excel spreadsheet, and that you can sort of mass email patients about after-hours care that's available, or if any, during flu shot season, or you want to just communicate outward to your patients. Patient education, incredibly important. Frontline communication, so the greatest ally you have within the office is your front office staff, so I encourage you to leverage them as much as possible. So when a patient wants to schedule an appointment, you need to think about, can the patient's concerns be addressed over the phone? Now that you are being paid in a capitation payment, so you're basically being prepaid for care, does that patient really need to come into the office for a prescription renewal? Does this issue need to be addressed by a physician? Great question. If you have an allied health practitioner within the office, does it make more sense for them to actually take that call? When a patient is not able to see their own faux physician, what do you do? Is there another available faux physician to see the patient? Is the patient aware of the value of the faux and the cost of not seeing somebody within the faux? And is this person able or willing to wait until their physician is available? Obviously, depending on the wait time and the concern that the patient has, the reason for them calling in. Very important that there are a variety of tactics used when patients are calling in order to try to get them to seek care within your office, and if not within your office, then at least within the faux itself. So let's talk a little bit about Cirrus. We have a proprietary outside use management strategy that we use with all of our existing clients. So the process involves, we use proprietary software to determine patients' outside use patterns and trends. That data that I spoke about, where you receive a package every month from the ministry which shows you which patients are seeking care outside of your practice, we take that, put it through our software in order to provide you with patterns and trends of your patients. We then analyze that data to determine which patients to move from the roster to fee-for-service. This is what's really difficult by using the Ministry of Health reports, because it doesn't aggregate the data for you. It just shows you month over month who the patients are that are going outside, but it doesn't ever do any type of cost-benefit analysis in terms of, well, the patient is 80 years old and I receive X amount of capitation, so although she's gone outside of my practice 3 times, perhaps I'm still earning more income from her by having her on the roster versus not. So we take all of those things into account for you. We come at it obviously from a business perspective, and ultimately leave it up to the physician from a medical perspective to determine whether to keep that patient rostered or seen through fee-for-service. Also, we put a program together in order to educate patients on what it means to be in a faux. Incredibly important. Also ensure that frontline staff are very well trained, understand the faux program overall, but access bonus in particular, in order to deliver key messages about access. So within the actual analysis, just at a bit of a high level, we show you which codes contribute to your specific outside use. The majority of the codes, and this is just a snapshot of the report, the majority of the codes, as you can imagine, are always A007, but it's some of the other codes that pop up that we really want to take a closer look at. We're also able to show you what days of the week see the highest amount of outside use. As mentioned, Monday through Wednesday typically are the highest within physician practices. And the reason why we say that the outside use program and access bonus program is a daytime access issue is because the A888 is billed on the weekends. So you see Saturday and Sunday are lower. That's because the A888 is billed, which does not contribute to outside use. We also show you, in a sort of a formulated way, who your top contributors are. So we would take all of that data in order to distill it down for you to show you a cost-benefit analysis. So we show you how much income you earn from these patients within a defined period, and then how much are they costing you. So you can see here with this top 20 list that you are earning $18.90 from them, but they are costing you $5,200 approximately, which is being reduced from that $62,000 per year. So it's actually costing you more money to have them on their roster versus how much you're earning from them through the capitation payment. We also sort this by, on the right-hand side, you can see the percentage breakdown, where we show you anybody that's over 100%, they've actually negated the financial benefit of seeing them through the roster, basically being paid through capitation. So we run all the math for you in order for you to determine who it makes sense to potentially deroster. Further from this, though, and this is the part that's always very interesting to everybody because they're always shocked at the people that pop up on this list, we're able to show you the actual codes that contribute to the patient landing on your top 20 list of highest contributors to outside use. We show you the number of services happening over the course of a number of months, and then also provide you with the earliest date of outside use in order so that you can make an informed decision of how far back retroactively you should potentially deroster somebody. We'll also make sure you're taking a look at the actual codes that are contributing. Part of the reason for this is that you want to look at a time in a patient's life where they may have more outside use versus another time. Sports medicine is a great example of something that could be for a very short period of time. So although maybe you want to deroster them for a short period, but you want to certainly make a note to potentially re-roster that person once they're no longer going to that sports medicine physician. So we'll walk through a couple of case studies in the outside use management program that we've run. Case study number 1 is a faux group, which began with a negative balance of $117,000 in access bonus for the entire faux. It was an 18 physician faux, and 13 of 18 were in a negative access bonus position. In case number 2 was an individual within the group that began with a negative $20,000 in access bonus. And the group actually threatened that physician to actually be able to have to pay that money back to the group in order for the group to be able to, in order for that negative physician to not negatively impact the rest of the physicians with their access bonus payout within the group. So case study number 1, let's look at this a little bit more closely. In 2011, a GTA faux began working with Cirrus with our whole faux group management service. So not just the outside use, but just signed on with us as a client group in order for us to be able to help them with, a variety of the pieces that we work with people on with respect to, billing, scheduling, financial, after-hours scheduling, all of these different pieces, but access bonus is the piece we'll focus on here today. A key goal was to improve individual physician and group-wide access bonus attainment through the Cirrus Outside Use Management Program. So the member size, as mentioned, was 18. The total roster for all of those physicians was over 32,000, and the average roster size was around 1,800, so fairly standard across the province. Some of the outside use goals were to capture 50% of the physician maximum payment for the access bonus. One thing that I should mention is that you will never be able to obtain 100% of your access bonus, nor should you have the expectation that you will be able to achieve that. 50% is an excellent number. The only time I've ever seen anything above and beyond 50% was actually when the physicians were in a very rural, remote area where there was nowhere else to go. So if you can focus on obtaining 50% of that 62,000, you're in great shape. So some of the deliverables for us were to review and accumulate the tracking of outside use, so through the reports that we just walked through. We did this on a quarterly basis for them and provided them with a holistic review of access bonus through monthly access bonus reports. So every month, every physician would know where they're at, how much percentage they were able to achieve over the course of that month. And then on a quarterly basis, we'd actually show them that top 20 list of patients. We established a yearly plan to reduce outside use based on our best practices. And the outcome was that the physician, staff, and patients have increased understanding of how outside use affects the practice, attained a significant increase in access bonus capture rate, and significantly improved alignment of care provided within the revenue attained. So when we actually look at the dollar value, when we say capture rate, at the very bottom of your screen, you can see the numbers there. So anything that's in brackets is a negative number. So in September of 2011, when we started working with them, when they first signed on, they were negative $58,000 as a group. As we started working with them implementing the outside use strategy, we slowly saw them creep up to a positive position. And now, as you can see, September of 2013, they're obtaining 30% of their access bonus potential, an absolutely stellar number. So the FOE moved from a projected negative access bonus of $117,000 to a positive access bonus attainment of $270, an improvement of $400,000. 16 of 18 physicians in the FOE now have a positive access bonus. Let's talk a little bit more about case study number 2, the solo physician. In November of 2012, a GTA physician enrolled in the Cirrus Ontario Practice Development Program. This is our one-to-one program where we wouldn't, in case study number 1, where we were working with the entire group. Case study number 2, this is actually where a physician engaged us as a solo physician, and it's a one-to-one physician consulting program. And a key goal of her plan was to improve access bonus attainment through the use of outside use management strategies. The physician's motivations for engaging Cirrus included increasing income, work-life balance, and flexibility. They knew that this was a great opportunity for them, but didn't really know where to start, and didn't just want to go through willy-nilly derostering people because we knew that that would just reduce the monthly payments. So you had to go about it in a smart way. So the physician was a FOE physician, roster size of just over 1,100, and the average working hours of 45 hours per week. The goal was, again, 50%. We did this through review and cumulative tracking of outside use, provision of quarterly outside use management reports to show them the top 20 list of who their patients were that were consistently going outside of their practice, established a yearly plan to reduce outside use, and patient and staff education sessions. Came in, actually trained the staff on how to effectively message out to patients, as well as run the program within their office so that we don't have to be there, feet on the ground, every day to make sure this is happening properly. You want to train your staff to make sure that they are well informed to be able to take this on. The outcome is that physicians, staff, and patients have increased understanding of OU. They attained an increased access bonus and significantly improved alignment of care provided with the revenue attained. This individual's access bonus over time, you can see, was negative 30% when we started, and now, as of July 2013, is sitting at positive 49%, an incredible growth within a short period of time. So the physician moved from a projected negative access bonus of negative $19,000 to a positive access bonus of $25,000. An improvement of just over $44,000 within a very short number of months. The physician was no longer threatened by payback clauses of the group's governance agreement. So now, after the mid-year update with their access bonus, this physician no longer had to pay those monies back to the group. She was able to collect what she had earned during that period. So some key highlights of performance improvements. By analyzing outside use data over an extended period of time, physicians were able to de-roster patients retroactively to the first day of outside use, effectively cutting outside use and recapturing fee-for-service activity that happened during that period. Physicians and staff identified which days of the week were incurring higher levels of outside use and were able to adjust physician scheduling patterns accordingly. The Ontario Practice Development Program, OPDP, our one-to-one physician consulting program, is a 12-month program. It begins with an analysis of the current practice to obtain the baseline of an individual physician's practice. From there, we set goals based on that physician. Whether you are 5 years out from retiring, or you are a new mother that is trying to balance both work and your life, we take a look at the goals for your individual practice in order to come up with realistic expectations about the improvements that we can make within a 12-month period. From there, we come up with a 12-month program to help you and your staff actualize what's available to you in the FIG and FO model. Included in this is quarterly outside use analysis of your roster. So we will show you the top 20 patients negatively impacting your outside use, the days of the week your access bonus is where it's most impacted, the top codes contributing to OU, and the codes being billed by the top 20 patients seeking care outside. We'll also show you the cost-benefit analysis of the top 20 users on your roster. So those sample reports that I showed you in earlier slides, that's what we would be able to do for you on a quarterly basis. We'll also help you within your office with patient communication, media campaigns, and staff education. The analysis, the outside use analysis, is offered as part of the one-to-one physician package or as a one-time investment as well. So the ROI for the one-to-one program is the average physician income increase of 14%. We pride ourselves on ROI. Without that, we would not be in the business that we're in. And you can see that there's an average of $12,000 just within access bonus alone, which is an average ROI of over 800% for the cost of the individual program over the course of a year. 12 hours per month were saved on administrative and roster management activities by leveraging Cirrus. As well, I should mention that it's also a flat fee charged per month, and we do not charge a percentage of what is gained for you. So the more and more your access bonus goes up, the more goes into your pocket. In summary, we want you to take preventative action. Educate your patients on what it means to be within the FO. It's important to reach out to patients that you do not regularly see within your office. Outside use is a daytime access issue. I know I sound like a broken record, but it's incredibly important. Provide openings in your schedule for same-day appointments. Be prepared to react. Analyze aggregated data to determine which patients to move from your roster to fee-for-service. Focus on Cirrus red flag codes to determine which patients are likely to be high outside use contributors. And derostering is an administrative action that will not change the level of care you provide to your patients. They will simply be seen on a fee-for-service basis. Keep an ongoing watch. This is why we encourage people to continue working with us over a period of months, because although you can purchase the report as a one-time analysis, it's not going to have the long-lasting impact you will need, because as mentioned in my very first slide, patient behavior does change over time. Assess the needs of your patients and review which days of the week seem to be busier with walk-ins and call-ins. And patient behavior changes each month, and ongoing tracking is critical to managing outside use. That's what we had planned for you today. If anybody would like to reach out to me individually, my contact information is listed. I will be touching base with everybody that is registered here today in order to talk to you a little bit more about your individual outside use situation and whether or not we may be able to work together to help improve that. And I thank everybody for signing online today.
Great, thanks, Andrea. We do have a few questions, so we have a little bit of time that we can go over the questions that we do have from our attendees.
Yep.
So Robert asks, I know there is a rate of capitation based on age and sex. Is there a chart or a website with information to determine the capitation payment based on age and sex? Example, 40-year-old man, what is he worth versus a 70-year-old female?
Right. So yes, there is, and that's smart because that's exactly what you need in order to be able to determine, you know, how many AO07s will it make. Will that rack up in order to reduce the bonus potential of somebody, let's say, 35 and male? Great question. I believe it's listed in your FO Queens agreement, the original FO agreement that you signed. If not, happy to share that with you. But you're right, that is what you need in order to have a bit more visibility in terms of the cost benefit.
Great. He also asks, I live in a rural community with limited options for patients to go elsewhere in southwestern Ontario. My outside use captures about 85% of my total access bonus. Would there be any benefit? Would there be any benefit to try and optimize this further outside of just doing the strategies that you've mentioned today?
Yeah, I mean, I think it's always good to, I actually ran this for somebody that was achieving 80% of their bonus, and there were a handful of people still on the roster that were taking away from that 100%. So it's still a great exercise in order to run the analysis, just to get a better sense of who the patients are that are going outside, because clearly there still are some, and take a look at it from there. But, I mean, 85%, that is an excellent number.
Okay, great. So next question, you've mentioned you can do retroactively remove OU for 6 months. Is this the maximum time allowed by the ministry?
Yes.
Okay.
Yeah, it's typical with the sort of the 6-month stale dating the ministry has on many other things, so just keeping with that.
That guideline there?
Yeah.
Okay, and as a ballpark figure, what is the monthly fee for the, I'm assuming, the Cirrus service? And I'm sure this is something that can be discussed individually with everyone.
Yeah, I mean, in terms of, I mean, we keep our pricing very straightforward. As an individual physician, we charge $425 per month, and that's for the ongoing program, where we would come in and analyze your current practice, work with your staff, and you to come up with a 12-month program. That's that program as an individual piece, and that's what we would charge $425 a month in order to do that. Included in that are the outside use reports as well.
Okay, perfect. I think we've answered all the questions that are on the panel today. As both Andrea and I mentioned, we will be sending out a recorded version of the webinar, and we'll be touching base with you individually once the webinar is complete. So again, I'd like to thank Andrea Rennie for joining us for this webinar today, and everyone else on the call here who took the time out of their day to join us as well. So I hope everyone has a great afternoon.
Thank you.
Thanks so much. Thanks, Andrea.